Well, my sincere thanks to Anthony, who has been working with us on sharing some of those insights over this last year. We're going to now have a broader panel discussion, and I'm joined by Professor Jonathan Barker and Professor Mona Bafadhel. And I'll invite them shortly to both not only introduce themselves, but give some reflections on the ways in which they have been applying opportunities, or seek to apply opportunities through life sciences to the work that they do. Can I, as we go through this discussion, remind you that you can engage in broader discussion through the chat function, but particularly may we invite you to become part of the discussion by posting questions, and that's in the Slido component, which Jill reminded you about shortly, just before. And Jill will help bring those questions to us as we go through this broader discussion. Now, with that, it is my great pleasure to welcome Jonathan and Mona. And perhaps, Jonathan, could I invite you just to introduce yourself, but also to say a few comments about the work you've been undertaking.
Thank you, Richard. My name is Jonathan Barker. I'm the Professor of Medical Dermatology at St John's Institute of Dermatology, which straddles both Guy's and St Thomas's hospitals and King's College London. And so I think it's pretty well integrated into King's Health Partners. I'm a clinical academic dermatologist, and my research involves the investigation of chronic inflammatory skin disease. But it's probably worth pointing out that dermatological disease, skin diseases, probably accounts for about 20% of all visits to general practitioners. I mean, that's pre-COVID data. And the burden of skin disease is probably a lot larger than is commonly recognized. There are sort of four main areas of skin disease that we face. There is skin cancer, there is skin infection, and there is chronic inflammatory skin diseases, and then there are genetically predetermined skin diseases. And the Institute of Dermatology at KHP has active research programs in all of these diseases. And more than that, really, all the clinics, our secondary and tertiary clinics, are run or have part of one of their senior consultants a clinical academic. So we're able to seamlessly integrate, hopefully, clinical excellence with research and training, all within the clinical environment. As I say, there are programs in advanced therapeutics as they relate to genetic skin diseases and malignant melanoma with therapeutic monoclonal antibody production and clinical trials. But my area is predominantly in chronic inflammatory skin diseases, of which the big three, so to speak, are acne, eczema, and my particular area, psoriasis. And I was interested in what was said earlier on about these important five things. I forget the name now.
The vital five.
The vital five. Because in fact, patients with psoriasis suffer from the vital five. They tend to be hypertensive, obese, and so on. So there's a lot of health issues attached to this population of patients. And our work extends from genetic discovery, and it's been very exciting times recently because some of our genetic discoveries have led to drugs which have this year been FDA approved, and we're waiting to hear what the MHRA and EMA says. We've been doing studies about trying to introduce the right drug at the right dose in the right person at the right time. And to that end, we now do therapeutic drug monitoring, which is all a result of the research that we've been doing at KHP. And then finally, many of the drugs we use to treat these chronic inflammatory skin diseases, which are often collectively referred to as the IMIDs, the immune-mediated inflammatory diseases, because there's similarities with rheumatoid arthritis and inflammatory bowel disease. We use immunosuppressive drugs to treat these patients. And this has been a big problem in the COVID pandemic. And so a lot of our work since COVID hit us has been around identifying patients and working out whether they really are immunosuppressed and what effect that has on COVID outcomes. and what effect that has on COVID vaccinations. And that information has been used by Public Health England.
Jonathan, just before I go to Mona to say a few words, but we were hearing from Anthony about the importance of the ways in which they're using digital information in real time. And your opening comment about the importance of skin disease, its frequency of presentation, particularly in primary care. Skin, one of the things that, of course, unlike other organs, it's very visible. And it should be very amenable to ways in which we could use digital approaches to aid diagnoses and, of course, utilising things like AI to improve the specificity and sensitivity of that. Do you want to just comment as to where you see things presently or where you think they can go in the future?
Well, this is a big deal in dermatology, and it's often referred to as teledermatology. And the main areas of progress have been around using imaging and artificial intelligence to help in the diagnosis of skin cancers. And there's been a few big publications from around the world looking at this, and increasingly it would appear that machines are being able to train to have the ability to differentiate between benign moles, nevi, and malignant melanoma with accuracy approaching a dermatologist. And as the AI improves, it's clear that I think that it won't be long before there will be aids there will be digital AI aids towards diagnosis of skin cancer. I see, though, that clinical utility primarily being in general practice to start with, and to screen out better because of the vast numbers of referrals that we get. And I can well imagine that such methodology will also be used to aid the dermatologist in their practice as well. So it is a big deal, and it's coming.
I mean, it's a very promising future. Do you want to reflect at all on what are the barriers? I mean, one might imagine that this is kind of ready to go. What are the barriers for us being able to implement such approaches?
Well, there is the technology itself, and it's while it's being validated, the clinical utility of it still needs to be established. I think that's actually one of the main things. I do think that while you're absolutely right that skin disease is very visual and it's all about the looking, there is a bit more to it than just the looking. There are other facets. And bear in mind that in that situation, we're only talking about a particular skin cancer, just one, which, although devastating if you've got it, is relatively rare compared with basal cell carcinoma, for example.
Yeah. Okay. We'll, I'm sure, come back to a number of these points and other issues. But Mona, I welcome you. I welcome you not least because I think this is your first annual conference, having only in the more recent times joined us at King's Health Partners, but perhaps you'd kindly introduce yourself.
Thank you very much, Richard. So as you said, I'm new to the KHP family, and I've been here about 6 months, and it's still really exciting, and I'm feeling very privileged to be part of this annual conference today. I'm a respiratory physician and a consultant within the Guy's and St Thomas's Trust. I'm also the new Professor of Respiratory Medicine within the university as the partner. And really what we see in respiratory medicine, and we've come through a lot, especially in the last couple of years with the pandemic, is we've understood the importance of lung health. And as you mentioned earlier, it's the organ that's exposed to everything, minute by minute, breath by breath. And what we're really excited about is how we can transform that understanding of lung health to be able to impact on the community and the patients that we serve. From my own personal interests, I'm interested in chronic obstructive pulmonary disease, COPD, which is a major health burden to the healthcare systems in this country, locally and internationally. We have to impact on the way that COPD affects patients, all the way from the inflammation that's going on in the lungs to the implementation and the symptom burden and quality of life. So there's a wide spectrum from lung diseases especially that we need to tackle. With COPD, there's also looking at these acute episodes where people feel that they're getting worse. And I would say to everyone listening in, this is a frequent episode. It's estimated that maybe every 20 seconds a person with COPD is having an acute exacerbation, needing some help. And so that massive burden is clearly impactful, and it's important for us to understand how we can transform lung health especially. I think I'm really honoured and privileged that we were part of the lung centre that we've developed recently. That's going to bring together the communities of excellence around the local community, from cystic fibrosis to interstitial lung disease to asthma to ventilation to critical care management. So I think we have a real breadth of understanding and trying to tackle and improving lung health. And one of the focuses from the lung centre is really to look at the whole life course of the lung, because we are now understanding that actually what happens when you're in the womb may be impactful to what happens when you're a little kid, to when you're exposed to pollution, to when you're exposed to work irritants, to when you're exposed to cigarette smoke, to when you're exposed to infections. So understanding all of that life course is going to be very important. And I will end with saying that we're learning a lot from our colleagues in other disciplines, for example, in dermatology or in rheumatology or in the cancer specialties. Finding and understanding that precise target for that precise patient, for the precise treatment, is going to be where we're going to really, I think, be able to challenge the status quo, and that's what we want to do within the Lung Centre for sure.
So I want to just pick up on some elements of that and perhaps start by congratulating you on even coming up with the terminology of a centre for lung health, because of course it would be natural to think about lung disease, whereas of course the whole trajectory is how do we stay healthy, and that requires us to have a better understanding of that life course that you just described. Now, both of you have reflected on the range of clinical problems that you see and your colleagues see within their clinical environment, ranging from some very rare conditions to what we have often called these more common conditions that we label with these rather broad terms. Jonathan has talked about chronic inflammatory skin disease, of course your own area of interest in COPD. But the reality is, of course, there are subgroups within this. And Anthony was also reflecting on how do we get closer to an understanding of those subgroups so that we can do, just as you've been talking about, target treatment more effectively, the right treatment at the right point in time.
Yep.
Jonathan, do you want to just give us some reflections of the work that's gone on in relation to chronic inflammatory skin disease in particular in that regard?
Yes, well, I was alluding to this earlier. It's really very exciting at the moment, and talking about the right disease talks about it follows that you're talking about disease stratification. So you have a very big disease which affects 2% of the population, like psoriasis. But increasingly we know that when we label something as psoriasis, there are actually within that there are some very specifics which would appear to be separate diseases. And actually you'd know more about the methodology than I would, of course, but we've applied various genetic techniques to looking at psoriasis, and we've identified a particular the subtype of psoriasis. The name is generalized pustular psoriasis, which is a rare but life-threatening form of the disease. And it's quite clear that this has a completely different genetic makeup to the broader common forms of psoriasis. And as a result of those genetic studies, we know that there's a pathway that's disrupted, called the interleukin 36 pathway, that's very, very clear. A company has now developed a monoclonal antibody that targets interleukin 36. So it's a therapeutic targeted monoclonal antibody. A single intravenous injection of this drug in phase 1 and phase 2 studies will lead to rapid resolution within a week, and that response is likely to last for up to 6 months after a single injection. This is a dramatic improvement in our ability to treat this disease, because standard psoriasis drugs don't work anywhere near as well. So I think that's a fantastic example of what you're alluding to.
So, and just so folk listening in have a sense of how long it takes to go from, an initial observation, which, as you just indicated in this instance, was a genetic observation, to getting something into the clinic and into a patient, the duration of time?
Sadly, 10 years.
And that's probably better than we've been achieving in more recent, in other forms of drugs where the target hasn't been so well validated.
Absolutely right.
Where typically you're looking at 16, 17 or more years.
Yes. Yeah.
Mona, you're probably at a little earlier stage of thinking of some elements of this. Chronic obstructive pulmonary disease, clearly, again, multiple forms. Most of us at med school would talk that this was a disease of smokers. Life turns out to be more complicated than that. Your thoughts as how, again, you can start to tease apart the subgroups, as Anthony referred to them, in a way that will allow us to think about more meaningful treatments relevant to individual groups.
I mean, it's important always to reflect within these lung diseases, that, broad as they are, and sometimes loosely defined as they are, that there are indeed subgroups within the patient cohorts that we see. So the first thing I was saying, and similar to what Anthony said, it's about having the cohorts. Yeah. And then about following that, it's about having the data that you can interrogate within these cohorts. And I would add that actually you need to have the multimodality of the data. So of course we would be looking at the imaging side. We would be looking at the inflammation from the systemic inflammation from blood tests, to genetic assessments, to the inflammatory inflammation that's going on within the lungs. So, for example, by doing tests like swabbing people's noses, or collecting sputum inflammation, or doing bronchoscopy. So I think it's putting together all the modalities that we have at hand. Some are invasive, some are non-invasive. And some will allow us to have that longitudinal follow-up, which is always going to be key when you're trying to understand how different disorders based on different subgroups have a different trajectory. In the case of COPD, and in particular airways disease, we've got really close, particularly in following on from looking at the inflammation. So we can see that there is elevated T2 type inflammation that can actually, in asthma, has been revolutionized by identifying that group who have problems and then targeting with the monoclonal antibody, as Jonathan has said. So we've got some way there, but we've got a lot left to do. In the field of cystic fibrosis, for example, we found the mutations and we've found great targets. And, we can really revolutionize treatments for patient cohorts that would have had potentially quite a poor amount of lung health throughout their lifetime. So I think we learn, but we have to put all the pieces together.
Great. I'm probably going to come back to this issue of cohorts, but Jill, I wonder whether there's any questions coming from the audience.
There are lots of questions coming in for Jonathan and Mona, which is fantastic. First question from Dr. Jean O'Hara about reducing health inequalities. And Jonathan, recent focus on lack of considering clinical signs and ethnicity and skin colour. Yeah. And how are we in a position to move forward on that and reduce health inequalities by being much more focused around the ethnicity of our population?
This is a very, very, very important point, and it's a big point. And in my area of chronic inflammatory long-term skin diseases, this is a real challenge because most of the diagnoses that we have are actually clinical diagnoses. Histology is often very unhelpful, and there are no blood tests or imaging tests you can do. So it's what the doctor thinks, and it can be a big issue in skin of colour, because one of the primary physical signs in skin disease is redness, what we call erythema, and you don't see as much redness in skin of colour, and so there is at a national, and indeed international level, there is a big drive around education, around making sure that training includes skin of colour as well as white skin to make sure that the physical signs are well developed. And it's fascinating that if you then look in clinical trials and indeed real life data with cohorts, which maybe we'll come back to, is that outcomes in people of skin and colour seems to be worse than in white skin. And the issue is, why is that? Is this because the science is all around particular cohorts, particular ethnicities, or is it because you're missing important clinical signs because it just looks different? And we need to work this through, but it's just a very important point.
It is, and it's certainly something that I think King's Health Partners, partly reflecting, of course, the diversity of the populations that we serve, have to be well placed to focus on, because and there will necessarily be multiple dimensions to it, and we may well have a chance to just reflect a bit more. But Jill, a further question?
So a question for Mona from Dr. Tom Fowkes about just the opportunity, as Mona says, huge volume of patients in respiratory, and what's the opportunity both with our data and our science knowledge now to build pathways that can be focused on care closer to home and care in that community area, and what the opportunities might be, Mona?
Yeah, no, so thank you for that question, Tom. I think there are lots of opportunities, and I think that's the first step. Of course, with opportunities comes challenges, so we've got to almost be working in a seamless way, and I think we can do this within the partnership as well, where we're bringing together what we do at the different stages of healthcare, from the primary care, from the community care to the hospital care. And I think linking up together with great clinicians who are physicians, as well as allied health practitioners, from nurses to the pharmacists to the physiotherapists, with the scientists as well. And I think having that group of kind of expertise with patient representatives is going to be how we tackle what we need to do as a community. And so I think I'm excited by that opportunity, but really recognising that we have to do this as a family and learn what others have done already within KHP. That's what the plan would be.
That's absolutely brilliant. And there's a question from Mevhibi about how we might see the role of patient-centred outcomes in identifying those subgroups for personalised treatment, personalised solutions. I don't know whether Jonathan or Mona wants to come in first on that.
Maybe if I start, actually learning about patient outcomes and patient experiences is really important. We've recently done some work and spoken to nearly 350 patients with COPD across Europe, so different languages. We use translation so that actually it was familiar to their language. And we learned that patients actually do want us to do tests. They do want us to listen to them. They do want us to spend more time. They don't mind having more follow-up. So actually, therefore we can learn what our patients want by understanding that patient-reported experience as well as that patient-reported outcome measure.
Mm-hmm.
Yeah, I mean, back to your point about dermatology being a very visual specialty, of course, the patient can see their problem better, probably, than the doctor can. And if you look at patient-reported outcomes comparing what the patient thinks about their problem compared with what the doctor thinks about their problem, it's interesting how much variance there is. And the bottom line often is that the doctor isn't taking the patient's perception of their disease seriously enough. And so this is, again, for us, isn't it, a very important thing. And actually, it's been, for many of our chronic diseases, NICE has used patient-reported outcomes as justification for funding drug, more so than the physicians' global scores, for example.
Can I just take you both to, and again reflecting on the comments that we heard from Anthony Rosens and Hopkins, with that incredible emphasis on the utility of data and the integration of data with multiple measurements that are being undertaken, which are, and as you've just indicated, actually most patients want to have a sense that they've been appropriately investigated and understood. My question here is as much to do with the utility of that data, we are not short of data. In fact, we're in a position where we can start to imagine even larger data sets emerging. Can I ask you both, and you've different stages of your careers, the training of our next generation of our health workforce? I mentioned some of this in relation to our impacts, and in particular in relation to the utility of data and data science. Mona, you might offer some initial reflections of how we will ensure that that workforce is enabled to utilise that data in a meaningful way.
I think utilisation of data that's readily it's readily collected, it's readily available, and we know patients are wanting to have that looked at because it's being provided. I think that's going to be really important. One aspect, particularly with what Anthony has said, is actually if we standardise how we collect it and we put a real focus on collecting it in the right way, from the methodology that we do it, how we collect it, and then how we interpret it. So there's got to be structures that it's almost, it's not for everyone to analyse, because then people can, you could find that there are then flaws in that way, but it's a set programme of work where actually there's a standardised way of analysis. For the future generation of the workforce, actually being able to interpret big data sets is going to be quite important. And I think, I remember as a medical student, learning about epidemiology was probably one lecture, right? So learning about epidemiology and big data set interrogation, or in fact computer sciences, may actually help influence the way our workforce looks at that in the future. And that could be across all of the medical sciences, in my opinion.
And Jonathan, as you reflect back on your career, the transformations in relation to data and the ways in which that's now impacting upon your clinical service and activity.
Yeah. Well, and first thing, I just completely agree with Mona. It's a sort of generic thing, is that the next generation needs to embrace the bioinformatic approaches and learning how to use all this digital data, because it's absolutely crucial. I mean, I do think there are quite a few barriers, particularly in skin diseases, partly because the international classification of diseases is really poor for some disease sets, including dermatological diseases. So having accurate data, as you know, if you put junk in, you get junk out. Trying to make sure that the data is clean and good is actually quite a challenge. But back to the other comment about looking back, I mean, it has always been the way that the usual rate-limiting step in research are the patients to study. And so starting early with your data sets and your bioresources is terribly important, and it should be integrated into clinical practice.
We may try to reflect and come back to that as a sort of final wrap-up. But Jill, can I just see if there's further questions from the audience?
We've got 3 more questions, Richard. So question for Jonathan from Professor Mark Ashworth, Professor of Primary Care Research at KCL, reflects that a number of GPs are quite nervous about missing melanoma. And what's the opportunity for AI to help with this?
Yes, well, this alludes to the point that Richard brought up at the beginning, and I think that this is an absolutely terribly important thing, and the opportunities using imaging and AI to aid GPs in the diagnosis of skin cancer, I think, is absolutely huge. There have been huge advances recently in the technology that allows this, and I'm sure it will, within the next 4 or 5 years, within the UK, it's going to be possible for technology to aid GPs. I think that's the first place that this technology will be introduced.
That's brilliant. And then, Richard, just the last 2 questions. So a question for Mona about COPD and smoking, and would there be any COPD if there was no smoking? So I'll let Mona think of the stats on that. And then the final question for both of you, actually, about the role of climate change in both skin conditions and lung conditions. But Mona, do you want to just talk to us a little bit about COPD and smoking?
Yeah, so COPD is often caused by smoking. However, it's not the only cause, and that's what's really important. So exposure to pollution is important, and that probably links in with the climate change aspect as well. What happens in utero is clearly going to be important. The effects of numerous infections, for example, in your life course of your lung, is also important. So I would say that although smoking is certainly one intervention that we can do to try and reduce the amount of COPD, it has to be acknowledged that there are also other interventions that we need to think about. But it is a factor for sure.
And so perhaps both of you would just reflect on the climate change question. And it's pretty obvious that in both of your domains there is a very likely and very significant challenge that's going to represent. Perhaps first in relation to skin disease, which I suspect is self-evident.
Yes. Yeah.
Greater sun exposure is going to bring its own problems.
I was just, while I was waiting to answer this, I was just thinking about, I mean, there's two things here. There is the sun exposure, which of course is a huge deal.
Yeah.
And then there is the rising temperature, and I'm not sure specifically whether that has much of an impact, but there are others who may. But the sunshine is a huge issue. So we know it's a major driver for skin cancer. And it's possibly a driver for other events as well. And in dermatology, we talk about two forms of skin aging. There's chronological aging and photoaging of skin. So photoaging is, if you like, is aging accelerated by sunshine, and consequences of that include skin cancers, but also include other things, issues of skin like thinning of the skin or inflammation of the skin. So yes, changes in sun exposure are a huge part of the work that we do.
Mona, your thoughts on that in relation to lung health?
Yeah, so of course the lung is one of the main first points of what we breathe in, right? So everything we breathe in is therefore going to impact on what happens to our lung health. And so with the climate change and the pollution, that is one big step. Of course, changes in the climates affect patients with chronic lung diseases. So when there's acute cold or there's acute heat, patients with underlying lung diseases can really feel that. We recognise also that there's an increased risk of asthma attacks at times and when there's acute weather changes such as thunderstorms. So all of these things, as they happen, we're going to see an impact on our patients with chronic lung diseases. Add to that is, of course, many of our lung diseases are treated with inhalers, our puffers. And there's a new drive as well to reduce the amount of potential effect of that climate change and the CO2 from the production of the inhaler. So there is a big drive as well from the scientific, pharmaceutical and political environments to try and drive and remove that, so we are not impacting on carbon greenhouse gases really.
So for both of you, if there was a risk that I think we could fall into, we'll use our health data as an observatory platform. We'll see that the very things we're saying will happen. How do we move away from watching that happen to being able to intervene much earlier? Don't know whether is it solely about creams that will offer us barriers to sun exposure?
Well, yes. I mean, it's as you know, it's a huge, great industry. But yes. I mean, I think with respect to the sun and the skin, we've known about this for a long time, well, actually, we've known about it for a long time in white skin. I'm not sure if we know about it quite so much in skin of colour, to be honest with you. But the experiences from Queensland, Australia, from many years ago, have filtered in across the Western world, and sun avoidance behaviour, sun clothing, sun creams, all of this type of thing are there, and I think that's kind of in the public psyche, but it just needs to be more. Other than behavioural change, I'm not sure there's much else going on at the moment.
And in the lung?
Yeah, so I reflect on what our colleagues in other organs are doing, really. So we think about gut health, and we think about, taking our probiotics to protect our gut. We think about skin protection. we think about mindfulness, we think about exercise for cardio protection. I would love to think about, especially of all the things that are external to what we can do as a population, think about maybe might there be an opportunity for pneumoprotection, something that we can protect our lungs for. Of course, we learned during the pandemic that mask wearing was certainly an indicative way of trying to protect us from getting viruses or passing on viruses. So I think that it's obviously not ready yet, but there is potentially a future of how we can think about adding things onto for lung health.
Can I just check, Jill, anything else from the audience? Well, if not, just as we move to conclude, probably what I think I've heard, not only from the conversation we've had here, but also through Anthony, is there's a real opportunity now to think about the disorders and diseases across their life course, to think about the fact that these are not single entities, they're typically multiple different entities that we label under one condition. We've been incredibly slow to disentangle those. And we can and do tend to describe this now as precision medicine. But we're still a long way from this. So, and yet there seems to be some general rules that we might wish to apply across what we often and traditionally offer up as our specialties.
Yep.
So what would you wish KHP to put in place to accelerate the opportunities for really driving precision medicine in the areas that you focus on a day-to-day basis? Mona, perhaps you'd just...
Yeah, I would say that it's bringing the communities and the expertise together across the disciplines. And I think we're in a real fantastic opportunity. Well, I feel I am being part of as a new member of the KHP community. It's bringing together the imaging experts, the data experts, the computer science experts, the inflammation experts, the patients, the policymakers. It's bringing them all together in a room so that we can ask perhaps what are the important questions and how are we going to tackle each of these important questions in a step-by-step process. And I think that is really exciting. And although it might feel quite overwhelming or quite like a big challenge, actually I don't think it's that far away. And so I would hope to see that is something we can influence within the next 5 years and then influence more within the next 10 years.
Terrific. Jonathan?
Well, I agree with all of that, bringing people together and having all vested interest in one building or one place at one time. Although, of course, we work very closely with the geneticists, the immunologists, the rheumatologists, the gastroenterologists, but actually we don't work so closely with the respiratory medicine, and hopefully we will do as a result of this. But the other thing, I think, if you're asking what KHP can do to help, sometimes trying to involve patients in clinical research is quite challenging, particularly if they're patients in another hospital. And if there was an easier way of trying to get the whole community, patients, families, physicians, scientists together, I think that would help enormously.
I'm glad you've raised that point, because my final comment or question to both of you, and it has come up through the earlier question around health inequalities, but in many ways, we know we do not get full representation from the population in most of the efforts that we undertake, in invitations to engage in clinical trials or indeed in broader research programs. And there is a very significant challenge to us here. Mona, again, in your own experience and your thinking, ways in which we can more effectively bring not only the patient but the population to be part of the ambition. And I don't know whether you've got any immediate reflections on that.
So I would say it's reaching out to the community. So reaching out to the kids at school, for example. It's reaching out to the community centres or pillars of where people engage from their cultural understanding or from their religious backgrounds. And I think we have that opportunity. I know that what worked well when we've been trying to recruit patients, particularly during the pandemic, we were able to target the mosques, the synagogues, the churches, the community centres and the halls. And actually that actually does work. So I think it's about putting the communities together to realise that this is important for all of us, not just the one group.
Mona, Jonathan, I think we're now reaching our time, but can I thank you both very much for offering your reflections and giving us some indicators of where we need to put our efforts next. So my most sincere thanks, and thanks to those of you in the audience who put forward questions.